Much, and unfortunately the academic FYs who are going to present today have been unable to attend, so I'm very grateful to Claire McRae for stepping in to present to us today the journey of staff development for teaching. Now, many of you will know Claire, who is the Staff Development Officer for teaching, I've got that right, and who's been in post since 2009, basically developing teaching programmes for NHS staff to engage them with teaching primarily of medical students and primarily in the medical theme. So Claire, I'm very grateful to you for talking to us today about where have we come from and where are we going. I ask myself that all the time in terms of staff development for teaching. And welcome to Perth.
Okay, good afternoon everybody. What I thought I would do is just share with you the journey that I've been on since I started post as Staff Development Officer back in 2009. It's been a bit of a mixed bag of things. There's been a lot of barriers thrown up on the way. And we're in a position now where we probably need to make some decisions about where we go next with staff development. So this is me in my very first week in post. This was back down at Tay Park House, which was a really nice setting, very scenic, but very removed from the main hospital and the consultant workforce that I was expected to step in and provide training for. I was very enthusiastic. I had this vision in my head of what staff development would look like, and it kind of involved me leading the charge and this really attractive scenery with things that everybody would want to come and interact with. So the reality was a bit different. This is a giant box of Lego that I found in a charity shop recently, and I was so excited about this enormous box of Lego. And then I got it home and basically discovered it was a giant mess. So this was kind of my reaction when I discovered what my job was actually going to be like. There were a lot of kind of broken bits, a lot of dirty bits, things that did not belong in there. There were bits that were perfectly functional, but they were in the wrong place. So this is Connects, not Lego. And there was a lot of obsolete stuff. Again, more broken bits there. One of my favourite examples of workshops that were being run when I first came into post in 2009 was a workshop on how to produce overhead transparencies. I'm not sure whoever attended it, but... So one of the other things that was really interesting at that point, one of my colleagues who had had my job before had conducted a survey of all consultants in Scotland, and I was able to get in and access the Tayside data. And one of the most worrying things was that while 55% of consultants in Tayside said that yes, they did know about staff development for their teaching role, 45% didn't. Either they thought there was none, or they just didn't know whether there was or not. And they also did not feel that NHS Tayside was supporting them either in delivering teaching or in attending training for their teaching role. You can see the biggest group there is neutral, but that still means that only 29% actually felt actively supported. So it was time to go and have a closer look at some of this mess and see if there was any bits that were actually usable. And there was lots of sort of useful building blocks that could be taken forward into a structure. There were some really interesting, unique pieces that are quite hard to come by. And once you started getting in and sorting it out, there were bits that actually had potential to be built into something. So this is pieces for a vintage hospital set here that was complete when I sorted it out. So one of the things that we had that was really good was our postgraduate certificate in medical education. And at that point, there seemed to be this ambition that all teachers at some point in the future would go and become qualified in medical education. Now, I did not think that was realistic, and the data kind of backed me up on that one. So 68% of consultants in Tayside from that same survey did not think that a qualification would be valuable for them in their teaching role. and even fewer felt that it would help them with their career progression. And then when the survey had asked about people who had A, started and B, finished a medical qualification, and only 10% of the consultant workforce had actually started a qualification, and of those, nearly 40% did not finish it, with the most common reason for not finishing being not having the time once they'd started on it. So bearing in mind that undertaking a qualification in medical education is a big commitment in terms of time and a big commitment in terms of cost, this did not seem to be a viable solution for the NHS workforce. You may have come across the value expectancy theory of motivation before. Value is how useful you think completing something is going to be to you, and expectancy is how likely you think you are to actually get through it. So if our consultants did not value a teaching qualification, and 40% of them were likely to drop out of it, their motivation to actually start one would be very, very low. So this was kind of my first year in post, was getting to grips with that data and picking up on the work that was already being done around the workshops running, etc. Moving on into 2010, I decided that we needed a fuller needs assessment. So we had this data from the consultant survey, but it wasn't the whole picture. The Johari window here is a tool that we use when we're talking about development needs. Up in the top left corner there are the open needs. So that's the needs that both the teacher and the student, or in this case the developer and the trainers, know about. So those needs are out in the open. That's the ones that they told us about in the consultant survey. Then we've got some that the staff developer in this instance can see, these blind needs, but the trainers don't see. They're saying, I don't need that. So things like maybe our student feedback suggested that lectures weren't as good as they could be, but the trainers did not think that they needed any extra training in giving a lecture. Then down at the bottom left there, we've got hidden needs. Those are needs that the trainers know about, but are choosing to keep hidden from the staff developer. And then we've got the unknown needs. Those are the ones that just all of a sudden flash out of nowhere and nobody predicted them. So what we were interested in trying to find out was, have I got this? Yep, what was in this blind box? So what needs were there that the consultants weren't reporting, and what was in the hidden box? So what needs were there that that's the ones they weren't reporting, and the blind ones are the ones that we knew about, but they couldn't see. So this kind of leads on to the question, is what you want always what you need? So the consultants have told us what they need, but it's not necessarily what they actually need. And if we give what they want to them, are they going to come? So if we organise all these development sessions to meet what they have said they need, will they actually show up to it? So going back again to the consultant survey data, consultants told us that the biggest things stopping them from coming to training were time, not being recognised for the effort that they were putting into it, cost, which could be quite high sometimes for postgraduate training events. The last two were lower, but there was an issue around geography, so where the training was physically located, and in Tayside that was a particular issue for PRI consultants because the training was always offered at Ninewells. And a lot of them also said, well, I'm coming up to retirement, I'm just not interested anymore, or I only work 2 days a week and you only run training on a Wednesday when I'm not in. So then that's the barriers that they explicitly told us about, but there were another set that came out through the free text comments. So this was things like the topics that were being offered weren't really relevant to their needs. Now, none of them owned up to this themselves, but a lot of them said, oh, my colleagues just don't value teaching, or they don't think that the training is very good. There was this lack of support from their employer, and also there was a feeling that the medical school could be providing more direction here. certainly the medical school's approach to this was to take a very back seat and say, these are our consultant workforce. They should be able to direct their own teaching. We don't want to tread on too many toes. But the message from the consultants was actually that they wanted a bit more direction from the medical school. So I'm throwing in another motivation theory for you here. Hertzberg suggested there were two types of factors that cause dissatisfaction, or that cause people to be unmotivated. The first are hygiene factors, and these are the kind of niggles that make people actually very grumpy, and they say, we're not coming. And then the second group are things that actively motivate them to go. So Hertzberg said, unless you deal with those hygiene factors, so unless you get rid of the things that people are grumbling about, you're never going to have much success in actually improving their satisfaction. So the factors that were coming out of the consultant survey did split quite nicely into these two groups. We had the time, the cost, and the location, which were all things that people were grumbling about. But then we had things like the recognition, the support, and the challenge that were the things that were actually motivating them to want to come. And unless we can address these three issues of time, cost, and location, we were never going to get anywhere with the more motivating factors. So at this stage in the development process, my focus was very much on providing training that was relevant to people's needs, that they were going to want to come to, and in providing information to support them in their role. So this was the direction from the medical school that they felt was lacking. So we organised a series of workshops, an education conference event. We sent out a regular curriculum update newsletter. We updated our course information booklet, and we developed a series of getting started booklets, or redeveloped them. They had been developed in the past, and we gave them a new look and a new feel. So moving forward then into 2011, if you've been to training events, there's a good chance that you will have seen the video of the people bouncing the ball, and you get asked to count how many times the ball bounces. And what most people miss is that in the middle of the ball bouncing episode, a gorilla runs through the room because they're so focused on the ball bouncing. So 2011 was when a couple of things happened that made me realise I'd been getting bogged down in the detail and not been looking at the right picture. So the first big thing that came in 2011 was that the Faculty Development Project for Scotland was set up. So this was a NEST-led initiative. It involved all 5 of the medical schools and representatives from the postgraduate deanery and the service. And it was set up because trainers in places, for example, Fife, who took both postgraduate and undergraduate trainees from different regions and from different medical schools, felt that they were being asked to do the same training 2 or 3 times by different organisers. There was a feeling that different guidance and advice was either competing with or conflicting with each other. So for example, the Academy of Medical Educators curriculum was competing with the Higher Education Academy Professional Standards framework, and people didn't know which one to pick. There was a definite feeling that all of these frameworks for educators were using too much jargon and far too much academic language for consultants who were out there working in practice. And a lot of them only focused on one role or one group of teachers, so they were very postgraduate driven, or they were very undergraduate driven, or they were just for surgeons. So the project launched with what has become known as the Competency Survey, and some of you may remember filling this in. It was a giant list. I think there was something like 80 competencies on this list, and it went out to consultants and GPs, and they were asked to rank these competencies in order of how important they were to consultants involved in teaching or training. And it was quite non-specific, so it wasn't postgraduate, it wasn't undergraduate, it was just, if you're involved in teaching or training, how important are these? So what came back out of that was a small list of very important. I think 18 essential competencies. A bigger list of, they're important, but not particularly high priority and not for everybody, that we didn't really know what to do with. And then a very small list of 7 or so that were felt to be just too specialised and should be really dropped off the end. So also kind of coming alongside this consultant survey was a recognition that people are going through a continuum here. As they progress through their medical training, they're developing teaching skills. So consultants are not starting from a blank slate. They've had teacher training in their sort of formative years. Most specialist training curricula have quite extensive teaching requirements. And why is there an expectation then that consultants should be starting from scratch with their development? And there was a lot of free text response to this survey. So what people were telling us was that looking at this list of competencies made them feel frustrated. It made them feel worried about what was coming next. And some of them, it made them feel very angry. Why are you making us do this? This is just hoops to jump through. Time obviously came out again, that too many people want it and there's not enough of it. Also, whereas in a specialist training curriculum, it's quite easy to pick out a skill, to go and demonstrate it and to be assessed on it. The teachers were telling us that for teaching, that's not so easy. It's very difficult to demonstrate some of these things. Despite trying to avoid jargon, people were still worried that there was too much of it in there. And a feeling that the more you tried to regulate teaching, the more people would just get their backs put up and walk off and leave it. And so you would end up with a very small pool of teachers. And another theme was that it was not the same for undergraduate and postgraduate, and it was very difficult to make this across the board. So this is kind of typical of the emotional response that we were getting from some people. The reasoning behind this being, well, I trained on an old curriculum. I was not taught by teachers who had been developed. Are you trying to say that I am a bad doctor? Which, it sounds a bit ridiculous when you hear it there, but that was a genuine concern that people had, that this was devaluing their own training and their own experiences. And then the other question was, well, fair enough, it sounds logical to put in training for teachers, but where's the actual evidence that it makes any difference? So this kind of puts us into this slight conflict situation between medicine, which is a very evidence-based discipline, and teaching, which has a lot of theory, but it's really down to the individual teacher and how they interact with their students and what works for them and their group of students. There is evidence out there, but it's limited, and particularly when we get to training for teaching, it's very limited. The kind of biggest pool of evidence available at that time was a systematic review of faculty development initiatives, which Steiner carried out in 2006. And the main conclusion for this was that there just wasn't enough evidence out there because people had not been evaluating their programmes, or they hadn't been publishing their evaluation data. So most of the studies were very small, they were single centre or one programme, and not really generalisable. And the reason that it was so difficult for people to evaluate is because what we're interested in is number 4 there. What results are we actually seeing? But what we're evaluating is mainly reaction. So we do a survey and we say, did you like the training? And people say, oh yeah, it was good. If we're a bit more thoughtful, we say, did you learn something from it? And they say, oh yeah, I did. If we're particularly thoughtful, we might test them. So we might find out whether they actually did learn anything. Very rarely do we go in and observe people and see whether they've actually changed their teaching behaviour as a result of attending the training. And the results, as I said, is particularly difficult because the results that we're looking for from faculty development is that our patients get better care at the end of the day. So, we're attempting to produce skilled teachers. which we hope will improve student learning, which we hope will create better practitioners, which we hope will improve patient outcomes. And with each extra level that you put on here, it becomes much more difficult to actually decide whether your intervention has had any impact. By the time we get up to here, there are so many other variables in play that you couldn't possibly evaluate whether your faculty development had impacted on that. So this kind of led on to thinking about whether training was actually the answer. If we look at the results that we want to see, there are a whole lot of things that affect these results. So the types of patients that are coming in, for example, might affect results. The types of students that we're taking in might affect results. And then we've got somebody's actual behaviour, so how they teach. And there might be other things on that than whether they've been trained to teach. So things like somebody's attitude to teaching. Do they think it's worthwhile? Are they doing it because somebody has told them to rather than because they want to? So then we're getting into do they have the knowledge and skills? Most of our teachers probably do, and it's in this job behaviour category that the issue is. So they know how to teach, but for some reason they're not doing it the best possible way that they could. So if there is a lack in their knowledge and skills, before we start thinking about training, is there another way that they could improve those skills? So maybe just having somebody observe them and tell them what they did wrong, give them some really good feedback, and that will help them to improve. So the issue is that as we come this way, the cost of interventions become much higher. So it's expensive to run training. It's less expensive to observe and give feedback if it's being done in the workplace anyway. It's presumably less expensive to create a supportive environment and hope that somebody improves just because they're in a better place. So this led us on to the next stage of the faculty development journey, which was about communication. So we had training in place, we had information in place, but were we telling both the trainers and the employers at board level or the organisation, were we getting the message across about why it was important, what might help, and what could be done differently? So then in 2012, the GMC introduced their plans to recognise and approve trainers, which in some ways was a good thing and a long time coming, and in some ways was not a good thing. So what the GMC wanted was for all trainers to demonstrate their standards. And in order to do that, they said that at a local level, the people running the education programme, so in our case, NES and the 5 medical schools, had to set criteria by which the trainers would be recognised. To demonstrate that they were meeting those criteria, trainers would have to produce evidence in 7 framework areas. And this is where it was left up to local providers to decide whether they wanted to include any more detail about what was covered in each of those framework areas. So this is where we took our 55 competency statements that were not essential but were fairly important and mapped them in against the framework areas. So where this kind of led to was that on a national level, we needed to allow trainers to cover all 7 of those GMC framework areas, but in a flexible way, because people were not going to have a one-size-fits-all model. So some of them were going to do training. Some of the training might cover all of the areas. Some of it might cover a few of the areas. Some of them might have alternative development that was equally valuable that needed to fit in there somewhere. Other organisations took the approach that they would just put in a mandatory training package, and every trainer would do it and they would repeat it every 5 years. The survey that we had conducted in Scotland said that wasn't what our trainers wanted, so hence why we ended up with this much more complicated model. So just to put some numbers on this, across Scotland, 4,443 doctors are currently performing roles that the GMC say need to be recognised. In Tayside, we have 547. That's quite high for a board of our size, and it's likely that that number will actually shrink down. On the undergraduate side, we have only 63 people on the GMC's very narrowly defined set of roles. On the postgraduate side, there are 530. So we did a survey of the people on our undergraduate trainer bank, and most of them said they had more than one role. So either they were performing more than one undergraduate role, or they were performing both an undergraduate and a postgraduate training role. So all of this data about trainers and who was a trainer and who wasn't a trainer and what they had to do and when they had to do it by had me tearing my hair out for a while in 2012. But we got over that and we moved on and we launched our centralised training programme. So up until then, we'd run ad hoc workshops. We had gone into departments and done training on request, tailored to their needs. But at this point, we felt that we were ready to launch a centralised programme. And you can see that I've got colour coding down here. We had coloured this for orange was foundation doctor training, purple was early skills training, red was advanced skills training, and blue were what we called teaching clinics. So they were updates on the undergraduate curriculum. So we had quite a comprehensive programme running at that time, and that kept me busy for most of 2013. Not much else happened then. So then we got to 2014, and things started to go wrong. This is a gooseberry bush that I used to have on my allotment, and you can see little holes there. And when you look closely, there are all these little caterpillars, and overnight these little caterpillars can strip a gooseberry bush bare to just spines. They're called sawfly, and that's kind of what it felt like was happening in 2014. It was a kind of constant fire putting out situation. We lost both of our administrators, one on secondment and one on maternity leave, and there was a big gap filling those posts. Because we didn't have our admin support, there was nobody promoting the training, so the numbers dropped, so we had to cancel a lot of the sessions. That doesn't look good, so you lose the goodwill of your audience. So it was all going a bit pear-shaped. But that did mean that I had a lot of time to look into the resourcing issues and the evaluation of the course. Evaluation, I could have presented you with the figures, but it was actually quite dull because the evaluations were very good for the training that we'd done up to that point. So I just gave myself a little medal and left it at that. So what we did find that we had time to do in 2014 was pilot a week-long course. Now, trainers had told us that at the start in the consultant survey, they wanted to come to half-day workshops or even shorter. So we weren't sure how this week-long thing was going to go. So we actually ran it with a group of medical students. And it fitted together very nicely. It included a space on the final day for observation. And the feedback, again, was quite good from that. So we did launch that this year. We ran it again. We opened it out to medical staff, and within about 2 days, the course was full. And we have a waiting list that will fill a second one. So obviously there is a demand for bigger stretches of training, but not at certificate level. So going on to 2015, I actually did win a medal, not a medal, but I got an award from NES for the development of the Scottish Trainer Framework, which was all very nice, except the reality of this was that this Scottish Trainer Framework needed a lot of maintenance, and loads and loads of questions have come in from trainers about what they need to do now. So the good thing is they are using the website. We can track their journeys through it. The other good thing about this website is that it lists all of the training that are run by Dundee, Glasgow, Edinburgh, NES, and it lists it by your role, whether that's a clinical role or an educational role, and it lists it by the framework area, so people who have got gaps can go in and they can pick one. And after this website launched, we saw a huge increasing in our training attendance. The other thing that's just happened recently is that consultant appraisal has gone live in SOAR for recognition of trainers. So anybody who is performing one of these recognised roles will now have to go in and check that they have collected sufficient evidence to show that they're meeting the criteria for recognition. The output that we're expecting from this is that a lot of trainers might drop off that didn't realise they were in these roles and no longer wish to do them. So that's the kind of big picture. Locally then, what we've got up and running at the moment is early skills development for new doctors. So we have some very specific workshops that we run for foundation doctors to meet their needs, being brand new practitioners. They're always very keen to teach and very overconfident about their teaching ability. So that's up and running. We run a separate course for academic doctors and some training for all foundation doctors. We're still running our core skills workshops, which are the kind of backbone of the development opportunities. We do have a number of advanced skills workshops, and now that we've got the admin situation under control, I'm hoping that we'll roll more of them out in the next year. And the other thing that we started promoting are departmental workshops. So we'd kind of taken a back seat on them, but now with recognition of trainers, departments are interested in this, and it is sometimes sensible to go in and give them tailored training that will meet all of their needs at once. And we also provide a lot of support for individuals, not just me, but our team as a whole. We have an NHS liaison officer who acts as a point of contact between service and the medical school, does a lot of the examiner recruitment. Teaching clinics we haven't managed to run this year because of the admin issue, but we're having a kind of one-hit wonder event in July to cover a lot of the topics that we would have missed, like using our new facilities, student support, recognition of trainers if anybody is desperate to ask questions about that. We host education events, so opportunities for staff to come and get involved in planning and setting strategic direction for education. We still produce a lot of printed and online material, and we offer sort of mentoring and support for people at different stages in their educational career. And we have a small amount of funding for people who do want to undertake qualifications, but I think that's about to get squeezed this year. So, moving forward into 2016, what's going to happen next year? The big development is going to be on the recognition of trainers front. The vision always was that the trainer would sit at the heart of this process, that they would be able to go into the Scottish Trainer Framework website, they'd be able to identify their needs, go in and book a course. The booking will all be done through, it's not Portal anymore, it's going to be Knowledge Network, which will talk to directly to the database, so it will feed in information about who's done what and when, which will also have a two-way link with SOAR. So it will inform SOAR of who is a trainer, and SOAR will inform the system of who has been through a trainer recognition appraisal. And trainers will also have the facility to upload certificates, etc., direct from this knowledge network area into SOAR. So the idea is that this will be very trainer-focused and very supportive, but that's still to come, and I can bet that it won't be on time. So this leads to the kind of final section of my model, which actually had to run all the way through. And this is the leadership and strategic direction for staff development. So some of the things that we need to consider in 2014 are whether or not we're still providing the right product at the right price, and that's not just the cost, it's also in terms of how much time people have to give up to attend and what else they're sacrificing if they're going to get involved in this, in the right location, and are we selling it to the right people? And then in the middle there, who are the people that we're targeting? Are we right to be spreading this thinly across the board, or should we be focusing in on specific groups with that may have more needs than others? So the questions that I'm asking going forward are, first, what are we required to deliver? So how are we going to meet the GMC's regulatory requirements, which may become legal requirements in the next few years? The funding that supports our staff development comes from Medical Act, and it has very strict accountability criteria that we need to demonstrate meeting. And also, how are we going to support the medical school and NHS Tayside's organisational strategies. And then there's a question of what we physically can deliver. Competence is not such an issue. We have certainly enough skill from our academic staff to be able to deliver most topics that we want. But then capacity is an issue. Every time somebody goes to run a training session, they're not doing something else. So whether or not we can deliver things comes down mostly to this capacity issue. And then there's the what should we deliver. So what is it costing us, both in terms of the financial resource, but also the human resource. And for example, if we take up rooms for staff development, they're not available for teaching. And who's benefiting? How many people benefit from it? Are we seeing any results from it? Is it adding any value to how the teacher or trainer perceives their role? And then there's the how should we deliver it? I have steered away from developing any online resources. There are lots out there, so we've mainly focused on face-to-face workshops, which allow us to model the skills that we want people to have. How are we going to meet what people tell us they want? And how are we going to stick within the budget that's increasingly being squeezed down? And then, when do we need to go back and review this again? When do we decide that actually that's so old now that overhead transparencies don't exist anymore and should have been cut out of the programme a long time ago? So this leads me into the kind of part where I'm hoping some of you might want to contribute. What do we do next? Do we still have an issue with awareness of what support and training is available for staff? Are the same barriers still there, or are there new barriers that we're not aware of? An increasing amount of our medical teaching is being done by non-medical staff. Should we be looking to engage them with our staff development programme? Or should we be opening the doors a bit wider and saying, well, okay, so that nurse is not teaching medical students, but they're still teaching nurses, and is there a reason they shouldn't come to our programme? Whether or not the recognition of trainers framework turns out to be an opportunity for teachers to get the recognition and increased value on their, that they deserve, or whether this poses a threat because trainers say not doing it and walk out the door. And going back to that question about supportiveness, trainers did not feel supported by NHS Tayside. Has that changed, or is it still an unsupportive place to work as a teacher? So those are the questions I would like to leave you with, but do you have any questions for me?
Thank you very much, Clara. That's an open invitation for questions. So I guess I'm going to kick off with one, if I may, which is about the medical school interaction and that idea that there is perhaps a disconnect between what people want and what people get, and how to improve that.
Do you mean how we are trying to improve?
How can we, or what do we do at the moment, and how can we develop that?
Yeah, so what we are doing at the moment is probably the wrong thing, because we are asking the people who come to training, what would you like more training in, and what can we do to support you further? Now, those are the audience that we've already targeted and engaged. What we don't know, and I'm open to suggestions here, is how to reach people that we're not currently getting to.
Questions? Ron?
I'm sure you've heard this before, but I mean, in our department, the big concern is, with the requirements now to be a trainer. So there are 6 consultants, all are trainers at the moment, but looking at the amount of paperwork you're going to have to do to demonstrate that you're a trainer is probably going to drop to 1 or 2. And at the same time, the amount of time that's required for trainees' assessments and filling in their e-portfolios is going through the roof. You just get the feeling that you're going to end up with something that all looks great on paper, but a trainer with no time really to sit with trainees, whereas you had one each, spend some time with them, that maybe wasn't all documented, and I understand the importance of that for quality purposes, but kind of you see it all going wrong, to be perfectly honest. Sorry.
So just for the people at the other end of the VC that maybe did not pick that up, that was about recognition of trainers and about the fact that the increase in regulation means there are probably going to be less trainers, but no increased time for the trainers. Craig, would you like to comment on that?
I think you've voiced a real concern that's probably in a lot of other departments as well. Locally, there's not much we can do about this because it's all nationally driven, what's coming through. The key thing is for NHS Tayside to actually have people who are in designated roles to have time in their job plan for that. And that's going to be something that's going to be going through in the long term, both locally and nationally, of how that's going to be happening. But as far as what we can do to support that is really just, as Claire's already went through, ways of encouraging ways of our trainers to get through the national hoops that are already put into place for that.
Yes, absolutely. I think the thing is to maybe try and discourage departments from deciding to go to just one or two trainers, which is the way they're all going to go. Sorry, just saying that to probably just discourage departments from going to just one or two trainers, which I think will be very difficult, which is where they're going to go, because otherwise you're going to end up with the trainees being shortchanged, I would imagine, because no one will have time to sit and go through these portfolios with them properly.
In a slight burst of optimism, which is out of character for myself, there is some genuine moves being put forward by JRC, PTB and all the colleges to try and reduce the tick box training exercise and actually move it more to being a more qualitative and more basis on the educational supervisor report. So hopefully there will be that individualised report aspect to it and less of the time-consuming tick box exercises in the future.
I mean, most of my training needs to be keeping up to date with how to fill in a new portfolio report because it changes so often. With the best will in the world, I seem to keep getting it wrong. The trainees also got me and then I filled in the wrong form again.
So I think that's another course you need to organise. Mary, sorry.
Thanks very much. I wondered about peer observation of teaching, because we did that for a little while and it kind of fizzled out pretty quickly.
Yep.
And properly set up, I think that's pretty powerful. Because changing behaviour in anything is notoriously difficult. But the thing we do know about changing behaviour is individual feedback.
Yep.
And if people could commit to 1 hour of observing a peer and trying to give thoughtful feedback, I think that might be quite powerfully motivating. And we'd learn from our colleagues. I would love to sit in a tutorial with Colin and learn a bit more about stroke. So what about that?
I think the evidence is that the person doing the observing gains more out of it than the person being observed, which is not a bad thing. I'm not saying that's a reason not to do it, but that it should be taken into account. So the observer is also developing, not just the observee. We did attempt, so I think the peer review scheme had fizzled out before I arrived, and we did attempt to reintroduce it. And the main problem that we had was with the quality of feedback that peers were providing. And it's quite difficult sometimes with senior colleagues to say you actually need to go and get some basic feedback skills training. So I think we should be looking to take that one forward, but that's the immediate barrier that I can see.
Any other comments or questions? Any comments from Perth?
Can I just comment? I think
Morning, thanks.
Found the session very helpful in just getting a general perspective, because clearly I don't want to be the angry man or the frustrated man in terms of some of these teaching perspectives, but I think I agree with Ron to an extent that sometimes we get caught up so much in the red tape of the actually providing documentation, and it actually takes away some of the natural teaching interactions that people have, not just in a ward setting. I think in clinical skills you essentially don't have to worry about the optimum management of the patient, but I think if we're over-regulating, I think we sometimes take away from some of the best teaching opportunities which can arise, and I think we can't always deal with that through regulation. I don't know what your views on that are.
I think we would probably all agree with that one.
Yeah, and I think, to be fair, the approach that has been adopted in Scotland has attempted to minimise the red tape as much as possible. So there is no mandatory training. It is down to individuals to deal with this. If you, as a trainer, don't want to collect any pieces of paper, provided you and your appraiser have a discussion about how you've developed as a teacher and you feel competent to self-certify, you can do that. So there is a will on the part of NES and the medical schools to make this as easy as possible for trainers and to keep it light touch. The GMC, on the other hand, are kind of shifting the goalposts a bit here. Their ambition when they started was very much that this should be supportive. It should be about value in trainers. It should be minimal bureaucracy. And now they really are looking at it as a kind of quality management check on who's doing good and who isn't doing good. And but there is enough local flexibility for us to offset that a bit, I think.
When we talked before the talk, one of the key things that Claire brought up was this issue of engaging non-medical staff, and I wonder whether people had any views on whether this is a resource that should be extended both to non-medics who teach medical students and junior doctors, but also who teach other professions.
Quite a lot of our excellent teaching in integrated ageing is done by non-medical people, one of whom is in this room. And, you know, we pharmacists, AHPs teaching formally, as well as nurses teach a lot informally. So I would have thought it would be inequitable to have such a system available which excluded these people who are making an increasingly vital contribution to delivering the curriculum.
And that we all hurt as a result.
I think I would like to say that we do, these sessions that we run are open to anybody who is involved in teaching medical students, so we certainly would not be excluding that group that you're describing. I guess my concern is maybe more about whether we could go a bit broader than that and just say any of our healthcare professionals, whether you're teaching medical students or nurses or AHPs, this is open to everybody, which we haven't done in the past. Although we don't turn people down at the door. If they're employed in NHS Tayside or the university, they get in. But we haven't actively sent it out to those groups.
You can only positively support training and send a message to training support.
A lot of the work in sort of cross-boundary teaching is done in undergraduate stuff, but actually when you look at it from a postgraduate level as well, some of the best teaching and clinical judgment in particular is delivered by non-physicians who are not so scientifically bound to their principles and think about it more from different aspects.
I think that's certainly something we will take forward then. Nick Richardson is running a group looking at interprofessional working, and that was one of her issues, was whether or not we could look at expanding this out a bit.
Well, if there are no further comments or questions, I'd just like to thank Claire very much for what was an extremely interesting and informative talk for all of us who are involved in training at any level. So thank you very much. What do you do with all that Lego?
I play with it.
I was going to take it home and try karaoke. Well done, I enjoyed you.
Thank you for coming. That mostly make sense, Jordan.
That was good fun chat at the end. I was worried that we were going to be silent, but yeah, that was good. The only thing that I was going to say, Marion said it anyway, because the students mentioned it, is the pointers and HPs and stuff. That should need to get
Oh, bye Fiona and Eleanor.
Bye, and as well. Useful comments that I put to
I mean, you've got to provide sort of loads of feedback, say, like, teachers, great from students, so soon that will cover it. I mean, most of it, teachers listening to other people's lectures, to be honest, but that doesn't count as formal training.
You don't need to have formal training.
You know, that's what I mean. You know,
it's
it's just, I'm not engaging in training, still go tend, but in fact, going to lectures all the time is really probably the best training. I mean, I've got a lot of Lego. I can do anything with Lego.
Took it talking on the Lego.
I'm just waiting for my children to go. My study's been taken over by their Lego. So I can build anything.
And then you'll be able to put them all together and build some kind of castle.
Oh, yeah, we do that. You go around, take photos of various cities, and then build a building.
You don't.
And then I let them up. I said, you can have that set. You know, some Star 6 is a lot great.